So, this talk is extremely difficult but important because medical therapy for Cushing syndrome has entered into a new era. We as endocrinologists are very excited to finally have some better tools to treat our patients with. And the type of paradigm shift that I see happening has not yet occurred because we all have to learn more about where the medical therapy with the new advances best fits. So this, I'm very excited about this talk, and I look forward to your feedback afterwards because it's not easy to give, not even to medical students or residents, young doctors, and so forth. But I'm trying my best. I would like to tell you that my goals for treating a patient with Cushing syndrome are very ambitious, and I would love to achieve them all in all the patients. However, it's not always possible. But I would like to reverse the clinical features. I would like everybody to be able to compete for, beauty contest if they choose to do so. I would like to see a biochemical normalization. I'm an endocrinologist. I really like numbers. And I would like to see these patients over and over again and not have evidence of recurrence. Also, I do not want my patients to pay too big of a price for the treatment they're getting. So minimal side effects and if possible, no endocrine deficiencies. Now, this is hard, but that's the ideal world. So in terms of treatment, as my colleagues before said, the main treatment for this, at least for the pituitary Cushing, right, is and for the adrenal Cushing, is the removal of the tumor that causes the problem. And in general, if it's a benign adrenal tumor, it's taken out successfully. End of the story. Happy ending. With the pituitary tumors, as you've seen, these are usually small problems, small abnormalities that cause a lot of problems. So the surgeons are definitely the first line of friends once the Cushing's has been diagnosed and localized to you, whether a neurosurgeon or a thoracic surgeon or an abdominal surgeon. They are the only ones that can cure this disease with a smaller price to pay. Radiation does not work in all cases. So no matter which type of radiation you choose, it's not 100% guarantee. And as time goes by from the moment when any type of radiation was done, the chances for that still to work, at least in patients with Cushing's disease, are slimmer and slimmer every year. The price to pay for radiation is the possibility of one or two, less frequently, all pituitary hormones become low. So endocrine deficiencies, your thyroid might slow down. It's not the thyroid's fault. It's really the pituitary not signaling properly. And same for the growth hormone, and so same for the ovaries or testes and so forth. And this is still a work in progress. Radiation methods and technique evolved quite a bit. So perhaps we're going to see that a certain type of radiation is superior to the other, but it takes time because the effect on the cortisol levels and Cushing symptoms will occur in the first couple of years after radiation, but then the deficiency, the potential for trouble in the world of hormone deficiency is still in the spectrum even a decade afterwards. So that's why I always said, find an endocrinologist that you like and stay friends with them because, just the way things are. Now, I also in the past had bilateral adrenalectomy next on the chronological list of treatments that we offer our patients, at least, for those with pituitary and ectopic HTH production. Not anymore. And I'm not really sure where to put the medications in this, and it's not an algorithm, it's just a bulleted list. That's the way you should look at this. But as I said, medications are now trying to find their place in this algorithm, and we're still to find out where. So just so you know, there is something, and you probably all know, there is something called the Food and Drug Administration. And the FDA will approve a certain medication for an indication after some patient, animal and patient, human data was submitted to them, and they have several committees and meetings, and they say, okay, it seems like it's working, and this is the potential of side effects, but it seems like it's warranted treatment. Let's go ahead and approve it. So we've treated Cushing's patients forever. This disease has been around since 1910 that we know of, right? Or the first two medications that were approved by FDA were approved in 2012. So when are the medications indicated? Whenever a patient deals with acute complications from elevated cortisol, I remember a lady who had very clear evidence of pituitary Cushing's, and we couldn't do her surgery for a few good months because she had a very significant resistant type of infection that we needed to clear that before sending her to the neurosurgeon, and we needed to bring her disease more in control, because the reason why she wasn't clearing the infection was because the cortisol was completely out of control. I've seen patients in whom all the blood pressure medicine classes were already on board, and the patient's blood pressure was still very high, and the potassium was low. I mean, that's not quite the ideal situation you want to put an anesthesia specialist in. It's kind of going to be a little hard for them. And the same with low potassium, the same with recent clot, that affected either the leg or lungs. So there are situations when we need to control the cortisol before the patient can take on general anesthesia. Besides those, there are selected cases that might not be that severe, but they are teaching and the school year ends in a couple of months, or there are all sorts of other situations. So for other selected cases, we use it before surgery. But in general, we rarely use a medical treatment before surgery. After surgery, you've heard, in the best hands, most patients do very well, although there is a risk for recurrence up to 25% down the line. So if this elevated cortisol occurs again or persists, one certainly has to consider medical treatment. And then if the patients are not surgical candidates, either too high operation risk, age issues, or unresectable metastatic lesions, that's very rare, unfortunately, in pituitary Cushing's, but sometimes in adrenal Cushing we see that, then we need to treat medically. So I like this figure because it tells you where everything works. So you can, if there is pituitary Cushing, pasireotide, also called Signifor, has been FDA approved, and it will act where the tumor is. Cabergoline has FDA approval for a different type of pituitary tumor, which is called prolactinoma. But there are some studies that suggest that trying cabergoline in the right case scenario might work. Then one can act at the level of the adrenal glands. That's where cortisol is produced. So, if you act there, obviously you're going to be at a short distance from success. And these affect the cortisol synthesis, its production at the adrenal gland level. And finally, the glucocorticoid receptor. So I look at this as a key in a lock, kind of. You want to open a door, and the cortisol is the key that goes in. And if you come with competition, with something that would bind instead of it, when the level of cortisol is high, then you would keep in control the problems created by the cortisol excess. You do not touch the pituitary gland, and you're not handling the cortisol levels per se. You do not act on the adrenal. You just act at every site in the body where there are cortisol receptors and try to compete for access there and decrease symptoms. And that's mifepristone or Korlym, which is also FDA approved. In fact, it's been FDA approved exactly 2 years ago. So we'll start with the adrenal glands players. They've been around for longest, and even though they do not have FDA approval, we've all used them. Now, even my endocrine fellows still get scared of this picture, so do not be too concerned. You're not going to be tested on this, just on my name, okay, at the end of the. So this shows you how complicated it is when you try to manipulate this. It's not just cortisol. The steroids means that it's more than cortisol, glucocorticoid. You have aldosterone, you have dihydrotestosterone, you have estradiol. So it's a complicated way. You cannot just block one part of it and not affect the others, and have to be very careful what you're doing. Most of our medicine, not all, but most, act right here where you see the dotted line. Now, you've already seen that two things are affected just from the way I drew the line. And in fact, the problem is not that the way you'd expect. You don't deal with low aldosterone when you give the medicine that inhibits this enzyme, but you deal with the consequences of accumulation of the deoxycorticosterone, the DOC, that in fact can cause problems similar with the aldosterone. So it's a little bit counterintuitive and complicated. These medicines are effective in reducing cortisol levels. That's what they do. They block the cortisol level. The level is going to go down. You look at the blood work and you know what you're doing. They do carry a risk of adrenal insufficiency. You might dial up the dose and then the whole production is put on hold. So that's something to be careful about. So we usually, at least I use this medicine as a bridge until definitive treatment takes effect. I talk to my patients and I say, we're going to use it for this amount of time, and this is our goal. And we have to have a plan B, afterwards. We're not going to stay on this for the rest of your life. The good thing about it is that no matter where the Cushing syndrome resides, whether it's in the adrenals or in the pituitary or in the lungs or in the thyroid, you can use this type of medicine. ACTH dependent or independent, it works because it works at the adrenal level, and this is the only place where the cortisol is produced. Ketoconazole by far has been the most widely used, and I think still is probably the most widely used medication for treating patients with Cushing's syndrome of any kind. You increase the dose, and at some point the effect will occur. But what we've also seen is that there is an escape from that effect. So at some point, even though the dose of 800 was working for you last year, might not work this year. It has a black box warning for liver failure, and the liver tests have to be monitored very carefully, and we cannot tell who's going to get this liver problem. And that's one of the reasons why I do not like to use it in the long run, because I like to be able to predict at least to a certain extent, what happens to my patient. And it can cause low testosterone in men, and in both genders can cause things like nausea and headaches. Metirapone has low potassium as a side effect, swelling of the legs, hypertension. It may cause hair in unwanted places in women, and has a tendency to cause adrenal insufficiency more commonly than ketoconazole. Mitotane is a very powerful agent, but has a very slow onset of action. It's powerful because it can destroy the adrenal tissue. This is what's called adrenolytic. So it's a great tool for those few and unfortunate cases of adrenal malignancy. Is poorly tolerated. It's something that you're really paying a really high price in terms of digestive and neurological adverse effects. And in fact, besides ketoconazole, even doctors have trouble obtaining, in U.S. at least, metirapone and mitotane for their patients. So moving on to the next slide, I would like to talk about glucocorticoid receptor blockers. We have one, mifepristone or Korlym, which has been approved. It blocks the cortisol receptor, but also the progesterone receptor. It does not interfere with the aldosterone that you saw on the other slide. As a result, the levels of cortisol or ACTH will actually increase. If you remember that feedback loop I showed you, if you block that final step, the body will react. The body's, and in particular the pituitary gland, is smarter than your usual doc. But the only thing that this means is that you're not going to be able to use these levels to gauge your treatment, that they're not going to help you as a physician. It may cause symptoms of adrenal insufficiency. It's not going to be something that is going to show up on the lab slip with an undetectable cortisol, but you have to be careful and see the patient and see how they're feeling and measure everything you can in the office, blood pressure, weight, anything that can be measured, you measure. And titration is based on clinical criteria. It's indicated based on the package insert and FDA approval in adult patients with endogenous, meaning, the cortisol excess is from the patient, not from the outside. Cushing syndrome, who have type 2 diabetes, mellitus, or glucose intolerance, and have failed surgery or are not candidates for surgery. It may be used in any type of Cushing syndrome because it works on its receptor. It causes a fairly rapid decrease in the symptoms that patients come to you with. The weight improves, the waistline improves, the Cushingoid appearance changes, depression improves, quality of life, and also plasma glucose. So all these things are something that are the result of blocking the effect of the cortisol. The main side effect in terms of the blood work, again, we endocrinologists look at that often, is the low potassium. So we're very careful and we start patients on potassium as necessary. Women may have some consequences from the progesterone blockage, so we always work with our friends gynecologists to make sure everything stays fine. And then there are other side effects, nausea, fatigue, headaches, joint pain, leg swelling that may occur. Not everybody will get all of them, and some will not get them at all. This is the study that led to its approval. It was called Seismic, very, very impressive name. And this is on a 24-week multicenter, means patients were tested all over the world. And they all had Cushing syndrome, and some had pituitary, some had adrenal Cushing's, and they all failed surgery or were not candidate for surgery. And there were 29 patients who had type 2 diabetes and 21 who had hypertension. So they split them into arms to see where would be the best favorable effect in these patients. And in fact, one of the important findings of this a good effect was the effect on the glucose. And those of you who have had diabetes or have diabetics in your family, A1C is what endocrinologists live by. What was your last A1C? Because it reflects like a 3-month average sugar. So there was a significant decrease in all the diabetic cohort with this medication. And then there was an even more significant decrease when they looked at those patients who were uncontrolled with A1C greater than 7%. And for those of you who are working with your doctors to get your sugars under control, you know very well that road from 8.5 to 7.2 takes a lot of work. Weight loss is another thing that they've seen, and there was 5% or more from the body weight in half of the patients and 10% or more in a quarter of the patients. As you can see here, it continues to occur as time goes by. This is up to 24 week, but it's hard to tell whether it's the medicine or blocking the cortisol effect per se, or whether the nausea and poor appetite also play a role. But as long as the patient tolerates, these are the results. So, moving on to the last site of action, the pituitary gland, we have pasireotide, also called Signifor, which has been approved a year plus ago. It's a somatostatin receptor ligand. Somatostatin is a hormone that is an inhibitory hormone. It's in our system, and it will inhibit the growth hormone. It will inhibit the ASTH. It may inhibit the insulin. It may inhibit other hormones in our system. And if you bind a drug to these receptors, you might get favorable effect in treating, for example, someone with acromegaly. We've treated patients with acromegaly successfully with somatostatin receptor ligands for many, many years now. But a somatostatin receptor ligand that works in Cushing's disease in patients with ASTH positive tumors, that is something that only became available recently. Because it works at the tumor level, will decrease both the ACTH levels and the cortisol levels. So because of this, it shouldn't be used in patients who have adrenal Cushing, and there is no mechanism that suits there. And the FDA states that pasireotide has been approved for treatment of adult patients with Cushing's disease, so the pituitary, Cushing, for whom pituitary surgery is not an option or has not been curative. The medication reduced urine cortisol levels in the majority of patients and normalized it in 25%. Most patients maintained lower urine cortisol level after 1 year of treatment. Clinical benefits seem to be more extensive than what the numbers said. So in other words, patients had improved body mass index, which pretty much translates into loss of weight, because you don't really lose height too much, hopefully, or gain height at that age. Blood pressure improved, and the bad cholesterol, also called LDL cholesterol, improved. And they've seen these benefits in the trials that led to its FDA approval, even in those patients who did not normalize their cortisol. However, they became better, they became lower. The main drawback for physicians who are prescribing this medicine is the hyperglycemia, which occur in a very significant proportion, 70% of patients. If diabetics, from the get-go, I tell my patients, you will need more, and you will probably need to start injecting something rather than taking pills fairly soon afterwards, within like 2 weeks. So we have to make plans to see each other again, send me those glucose levels by email, do something, because you have to check. If not diabetic, you should still be careful. You might still develop some glucose problem. There are some gastrointestinal side effects. We've been used with this from the other somatostatin receptor ligands, diarrhea, nausea, abdominal pain, and the risk for gallstones as well. And there is a risk of adrenal insufficiency. Whenever you're going to bottom out the cortisol levels too much, the risk is there. This is one of the studies that led to its approval, a 12-month study. And what you see here are individual patients who received a smaller dose, 600 in red, and a larger dose, 900. It's an injectable medication, by the way, subcutaneous, twice a day. And what you see, for each patient, there are 2 points, and that means that where they started, where the urine cortisol started, and where it ended up. And this dotted black line is where we would like them to be. This is the normal range. So we would like everybody to end up below that line. And as you can see, about a quarter of them did, and the majority, most of them, decreased their levels, with few exceptions that really went into the other direction or didn't change at all. So this was what brought pasireotide to its approval. And we now I think already some of you are thinking, wait, which one would be best for me, and so forth. And I can tell you that there are patients where we are being more creative, and we combine medications in order to get to control. And this is a study that combined 2 or 3 medications that act at the different sites in order to see whether there is a better effect together rather than as a unique medication. So my final thoughts on the medical treatment for Cushing syndrome is that the choice of medication has to be individualized. The most important part here is, what is that patient's main problem? Is it that there is a big tumor still left there, and both surgery, tumor residual in a place where a neurosurgeon cannot remove it in its entirety, and radiation hasn't quite worked, and there are symptoms and so forth? Now that's one situation. Or is there a clean MRI, or a patient with an adrenal tumor but who's still very symptomatic? Is it blood pressure or the glucose the issue? What does the patient main complaint is, and then individualize that choice. The other thing that I haven't gone into detail because it was way over this beyond the scope is that medications interactions with all these medicines are very important and can occur from simple things like having a bronchitis and being given an antibiotic. So, you want to keep your endocrinologist informed about whatever anybody else is prescribing. Dose titration and frequent visits and lab visits are usually necessary. And, we look at the patient, we look at biochemistry, we never forget to look at the tumor, wherever that was, as well as part of this. So, as I said, the jury is still out. We're entering a new era. There is still research going on, so other medications may come into play, and we'll see what the future brings. Thank you.